Well, good morning, everybody. Good morning. It's good to see you again. Hope you all enjoyed your evening and the wonderful accommodations, a little louder there, Shane, at the Waterfront Lodge. Beautiful place to stay, beautiful morning here in Saranac Lake. Welcome back to another morning. By the way, the reason that these white stickies are on your seat is because yesterday I neglected to, but today it's really important. The one great thing I learned, you'll see the whiteboard out there as you leave. The organizers have asked you to try to limit it to one. One great thing I learned from each of the attendees here today, if you do it and stick it on that board, it will give everyone a good indication of the success of our event. And I know it's been really successful so far. So before you leave, one great thing, stick it on the whiteboard and it'll be much appreciated. Our first presentation this morning comes via Zoom from SUNY Binghamton. You can see the title of his presentation, Vitamin D Oxycycline, Treatment and Prevention of Lyme Disease. Wes Kufel is a clinical associate professor of pharmacy and pharmacy practice at SUNY Binghamton, and he is, I'm told, set to go. So Professor Kufel, welcome, and the floor and the screens are yours.
Thank you for the introduction, and I'm happy to be here. Thanks to the planning committee for inviting me to talk on this topic. I wish I could be there in person. I'm actually in Washington, D.C. at an infectious disease conference called ID Week, and I had to give a talk yesterday, so I was unable to make the travel arrangements to be in Saranac Lake, but I love the Adirondacks and hope everybody's having a good time and learning a lot. So here are my disclosures. I have received some research grants from some pharma companies and served on an advisory board. I do want to just disclose that I currently serve on the board of directors for the Central New York Lyme and Tick-borne Disease Alliance. And my presentation content reflects that primarily of the Infectious Disease Society of America, or IDSA, and the CDC. Learning objectives for today are to apply nationally recognized clinical practice guidelines for the treatment of Lyme disease. And then we're going to look at evaluating non-pharmacologic as well as pharmacologic strategies for the prevention of tick bites and Lyme disease. So I wanted to start off with a muffin here. This is a poppy seed muffin, but it kind of looks like a tick muffin because the ticks are so small that they almost look exactly like a poppy seed. And I think this is one of the main challenges with Lyme disease is just the recognition and knowing when we actually are able to see ticks, what should we do? How should we potentially manage those? And that can really impact down the road, the treatment as well as the prevention. And I'm sure that this has been shared so far during the summit, but Lyme disease cases have just been increasing. So as you can see on these maps of the Northeast US, from 1996 to 2014, there have been a significant increase in the number of reported Lyme disease cases. And then when we look in 2019, it's even higher. And us being in the upstate New York area, we are in a Lyme endemic area. And these are the number of reported cases. So this is likely under-recognized of a lot of the cases that actually are occurring that just aren't reported. So looking at Lyme disease transmission, Lyme disease is actually caused by the bacteria known as Borrelia burgdorferi, which is a spirochete bacteria. So it's got kind of a spiral appearance to it, and it's transmitted via a tick bite. And the tick is known as the black-legged tick or the deer tick, but the more scientific term for that is the Zoetis scapularis. And that's primarily in the Northeast US. The Zoetis pacificus is more in the Western Pacific United States. And rodents and deer primarily serve as reservoirs for these ticks and really is involved in the trends and how the ticks are spread into different environments. So who's actually at risk for Lyme disease? Well, when we look at the geographic location, being in upstate New York, we automatically check that box. Wildlife and animal exposure, as well as wooded areas, there's typically more of a dense tick population. Lack of protective clothing, so the more skin that is exposed, there's more potential for a higher likelihood of tick attachment. And then lack of tick removal or recognizing that a tick has actually attached and what to do in those types of situations. So when we're talking to different people about Lyme disease, it's always important to obtain a proper travel history and a social history. So trying to get an idea of what type of occupation they may have. Are they maybe at a little bit higher risk of being more exposed to ticks than somebody who might not be based on their potential exposures? Have they traveled anywhere where there may be a higher density of ticks? So these are all things that are really important to consider when we're talking to patients about Lyme disease. So for the general stages or syndromes of Lyme disease, it's broken down into early localized and then early disseminated. So when we talk about early localized, that's what we most commonly will see with Lyme disease. For early disseminated, these are generally because the early localized was not recognized early enough, and it has progressed to these more disseminated presentations, such as Lyme meningitis, Lyme arthritis, and Lyme carditis. Then we go into post-treatment Lyme syndrome or chronic Lyme, where symptoms tend to persist despite receiving treatment. And then also we're going to talk about prevention measures. So for early localized Lyme disease, Dr. Polino had talked a lot about the diagnostics yesterday, but I just wanted to reemphasize that prompt recognition and treatment is really important. So we need to be able to recognize what these signs and symptoms are of early localized Lyme disease, and then make sure that these individuals are getting the appropriate treatment in a quick manner. On how we treat early localized disease, it really depends on the antibiotic being used. So for this presentation, I titled it Vitamin D for vitamin doxycycline, because as you'll see throughout the various stages of different Lyme disease, as well as some prevention measures, doxycycline will be coming up a lot. So we'll be talking about doxycycline a lot. And the treatment duration, so how long we're actually giving these antibiotics for, varies depending on which one we use. So doxycycline, I included the dosing instructions here as well. So 100 milligrams by mouth twice daily for 10 days. And these are the treatment durations that are recommended in the Infectious Disease Society of America guidelines. So this is actually a little shorter of a treatment duration than what has historically been thought of 2 weeks to 3 weeks. Now, again, this can be based on expert opinion and just general practice perspective. So sometimes some providers will treat for longer, 14 to 21 days. But based on the guidelines, a 10-day course of doxycycline is recommended. There are some other options as well. So cefuroxime, you can see the treatment duration is 14 days there. And then amoxicillin too, as well, being 14 days. What about using doxycycline in children? If you were not aware, doxycycline has historically been known to cause teeth staining in children, and that it should not be used in any child under 8 years of age. However, the American Academy of Pediatrics provided an update and change this recommendation that doxycycline can be recommended for short courses, so up to 21 days, without regards to a patient's age. And really what drove that was that doxycycline was not as likely to cause the visible teeth staining or enamel hypoplasia in children less than 8 years of age than tetracycline, which is doxycycline's antibiotic cousin. It's the one that was first developed and is no longer really used in clinical practice. And the other reason that this update came about was because for a lot of tick-borne infections, there's not really great alternative antibiotics to use other than doxycycline, thinking about other tick-borne infections besides Lyme disease. So we really need to weigh the risks and benefits of using doxycycline in children because we might not have any other options to be able to treat certain tick-borne infections. So this was a great update to see. So I wanted to start off with an interactive question, kind of go through a little bit of a patient case here. So we have a 6-year-old male was brought to the urgent care clinic by his parents for evaluation of a left lower extremity rash with a subjective fever. And you can see that this is the temperature that was recorded, and it's 38.3 degrees Celsius, which is about 101 degrees Fahrenheit, and chills for the past 48 hours. The rash is not itchy, but it does have a bullseye appearance. When we're trying to get that travel history, we find out that the parents said that they've been camping and hiking in the Adirondacks about 1.5 weeks ago, but do not recall any specific tick bites. And they did not perform any labs. So which of the following is the most appropriate recommendation at this time? Should we do some Lyme disease diagnostic testing first to see if this is Lyme disease? Should we start doxycycline, 100 milligrams by mouth every 12 hours for 10 days? Cefuroxime, 500 milligrams by mouth every 12 hours for 10 days? Or do a single dose of doxycycline, 200 milligrams? So I guess we can do it by raise of hands. Does anybody for A? B? C? Or D? Okay. Great job. Yep. So B is the correct answer here. So we don't do Lyme disease diagnostic testing. This is known as that early localized Lyme disease. So we just need to be aware of the clinical presentation or the signs and symptoms of Lyme disease. We do not need to do any diagnostic testing in this situation. For C, cefuroxime is an option. But the treatment duration for cefuroxime and amoxicillin that's recommended in the Infectious Disease Society of America guidelines is 14 days, not 10 days. So that's why C is incorrect. And then option D is for post-exposure prevention with doxycycline, which we'll talk more about later on today. So great job. So after I had already submitted these slides, I was texting Dr. Polino and Dr. Thomas because I just became aware of another new study that was just published in October this month. So just a couple of weeks ago. So this is hot off the press. So I figured I would talk about this briefly. And this study really kind of challenges how low can we actually go with our treatment duration. So this group in Slovenia was really trying to see, can we do even a shorter duration of doxycycline? So this was a randomized, open label, non-inferiority study in Slovenia. So randomized means that they got, there's like two different treatment arms where they got one study arm in one group and a different study arm in a different group. Open label, so everybody knew what they were getting, and then non-inferiority. So they were trying to say that basically one was not better than the other. What they were looking at is treatment failure following doxycycline treatment. And how they defined this was persistent erythema migrans, so that bullseye rash, so basically that didn't get any better, new objective signs of Lyme disease, or they isolated the Borrelia bacteria at a skin biopsy at 2 months. And that's something that is not commonly done in the United States, to do a skin biopsy, but it's something unique in this study. They had 147 patients in the 7-day group. So 7 days, they were trying to see is 7 days basically the same as treating for 14 days. And they had 147 patients in each group. What they found was that of those who had treatment failure, 5 patients or 3% occurred in the 7-day group, whereas 3 patients or 2% occurred in the 14-day group. And this met non-inferiority, and I included some of the statistical findings here, but basically all you really need to look at is this p-value, and it's the p-value is 0.64, and so it was not less than 0.05. So basically this met non-inferiority and helped to support that 7 days of doxycycline treatment was supported. Now, does this mean that we should be recommending 7 days of doxycycline in every single patient with Lyme disease? No, of course not, but I think it helps to show maybe we can do a shorter duration, like maybe that 10 days. But again, this was a patient population in Slovenia, which may be different than that seen here in the United States. But figured I would talk about it since it was something that just came out this month. So I wanted to quickly talk about doxycycline pearls. So doxycycline does have some interesting characteristics to it that I think we should be aware of. So after somebody takes doxycycline, it is recommended for them to stand up for 30 to 60 minutes after taking doxycycline. And the reason for that is it can actually cause some irritation and discomfort to the esophagus if somebody lays down right after taking it. So that's something that we can tell potential individuals that are taking doxycycline, just to help make it so that they're able to tolerate doxycycline better. The other thing is that it can make individuals more prone to sunburns. So it is recommended to wear sunscreen during prolonged sun exposures, or just to avoid them as much as possible. And then the last one is doxycycline, if it's taken at the same time as certain supplements in the stomach, they can actually bind together and it can decrease the absorption of the doxycycline. And we don't want that to happen because we're using doxycycline to treat Lyme disease. So we want to make sure we're getting as much of the doxycycline absorbed as possible. So what's recommended is to space the doxycycline from these supplements. And it's only certain supplements. And I've listed kind of the most common ones here. So if someone's taking iron or calcium supplements or magnesium supplements, these can actually bind to doxycycline and impair the absorption. There are some specific spacing recommendations, such as giving the doxycycline 2 hours before the supplement, or 4 hours, giving the doxycycline 4 hours after taking the supplements. But I think that's really confusing to tell people. So what I generally will recommend is to just hold or stop taking the iron, calcium, magnesium if possible while taking the doxycycline, because it's only going to be generally for 10 to 14 days in most cases. But if somebody is willing and able to do the spacing, that's completely fine as well. I just think it can make it for, I think it can make it confusing. So moving on into early disseminated Lyme disease, this is like Lyme meningitis, Lyme arthritis, and Lyme carditis. So Lyme meningitis, this is neuroborreliosis. These individuals may present with various central nervous system related signs and symptoms, such as headache, fatigue, fever, neck stiffness, and kind of unique to Lyme meningitis, it can affect the 7th cranial nerve and can result in what's known as like a Bell's palsy, as shown in this picture here to the right. For treatment, the preferred treatment is actually a intravenous antibiotic called ceftriaxone. And you can see that the treatment duration is longer here than what we saw for early localized Lyme disease, so 14 to 21 days. But again, an alternative here is doxycycline. So it's showing up again. And you can see the treatment duration is the same as shown for the ceftriaxone. For Lyme arthritis, generally these individuals will have limited range of motion. They may have swelling in the joint, and they will also have redness. They can also have redness, and it's typically only one joint involved, with the knees being the most common. And this may occur weeks to months after the initial infection. For treatment, doxycycline, here it is showing up again. You can see that these treatment options were the same as for early localized Lyme disease, but you can see the duration is much longer here as well. So 28 days for Lyme arthritis. For Lyme carditis, these individuals may present with dizziness, chest pain, syncope, palpitations, and if they end up getting an EKG, they may have some abnormalities seen on that, such as what's known as an AV nodal block. For treatment, very similar here to the Lyme meningitis treatment recommendations. So here's ceftriaxone again. This is that intravenous antibiotic. It's given for 14 to 21 days. One of the advantages of ceftriaxone is that it's given only once a day. So it's a little bit more convenient, even though it's an intravenous antibiotic. But again, as an alternative, doxycycline is here as well. Moving on into post-treatment Lyme syndrome. So as has already been discussed, these are like non-specific symptoms following the treatment of Lyme disease that may persist. And these individuals may have multiple potential symptoms. I've listed some of them here. There may be other potential symptoms as well. So fatigue, malaise, headache, arthralgia, so joint pain, muscle pain, and then impaired cognition, or kind of this like brain fog. Some individuals will report. And unfortunately, we really don't know why this happens. Persistent infection with Borrelia burgdorferi is really not thought to be the cause of these, but it's potentially some inflammatory response over time is what's leading to some of these potential symptoms. Chronic antibiotics or long courses of antibiotics are not recommended. There's no evidence suggesting a potential benefit of prolonged antibiotic therapy. This can drive resistance to antibiotics. So if they were to get a bacterial infection with a different bacteria, and we went to go to use one of these antibiotics, if they've been on it for a very long period of time, it's unlikely that that may work in the future. They may be more prone to adverse effects of the antibiotics as well. So it's really important to refer these individuals to an infectious disease specialist to help manage these symptoms. What are some potential reasons for the lack of response? I listed a couple potential ones, but there's a lot of other reasons as well. One is maybe the initial Lyme diagnosis was incorrect. So we put all of our eggs into one basket saying this was Lyme disease, but really maybe there's something else there, all right? Lyme disease was treated and then maybe another condition persists. Fibromyalgia, depression, arthritis, some autoimmune process. And then maybe there's some unknown immunologic response or inflammatory response or persisters of Lyme. And I think it's always important to remember to treat people and not treat laboratory tests. So if somebody just gets one laboratory test that may consider treatment or potential antibiotic use, think about the patient as a whole. So again, not just focusing on one laboratory test, but taking into considerations a lot of different patient-specific factors. And with using very long courses of antibiotics, it's not without some potential risks. So there have been various bacterial infections acquired during prolonged antibiotic treatment if given this chronic Lyme diagnosis. So here is an example of somebody who had passed away because they were receiving a 27-month course of intravenous cefotaxime, which is like the cousin to that other antibiotic we had talked about, ceftriaxone, because they ended up developing a infection from the line that the intravenous antibiotic was being administered into. Here is death due to Clostridium difficile, which is an infectious diarrhea, which antibiotics can put you at higher risk for developing, especially prolonged antibiotic use. Ceftriaxone-induced anemia was reported here. And then this last one that I have is basically, it was a man in his late 30s who presented with 4-year history of fatigue, abdominal pain, and loose stools. He was given a diagnosis of Lyme disease, but he was not in a Lyme endemic area. He did not report any history of erythema migrans, and the Lyme diagnostic testing results were negative. He was given IV and intravenous antibiotics, and then later on was found out that he had stage 4 lymphoma. And stage 4 Hodgkin's lymphoma more specifically, and had to undergo chemotherapy, and then later died 2 years because of the 2 years later because of the complications of advanced lymphoma. So I think it's just, important to recognize that maybe there are other potential reasons for some of these symptoms, and this is why it's so important to be followed and to see an infectious disease specialist. So now let's move on to Lyme disease prevention. So thinking about some non-pharmacologic measures, these can help prevent tick bites from occurring. So wearing long pants and sleeves now in the summer months, is that realistic? No. But the more skin that is exposed, the higher likelihood of ticks that ticks can attach. Wearing light colored clothing, because these ticks are known as the black-legged ticks. If somebody is wearing light colored clothing, it's easier to recognize and see those. Wearing closed-toed footwear, so sneakers rather than sandals, for example. Wearing insect repellent with DEET, tick collars on pets. But I think the most important one is doing a self-inspection for tick bites. So if you got done with a hike, for example, or walking on a trail, just inspecting yourself for any tick bites. I think that's really important, something that oftentimes goes under-recognized and is not done. And in a lot of New York State parks, there's a lot of really good education that's going on to sort of look for ticks, wear repellent, as you can see in this sign here. What to do if bitten by a tick. So if you do recognize the tick, use tweezers to grasp the tick as close to the skin surface as possible. It's recommended to pull upward with steady, even pressure rather than kind of wedging it back and forth, and then clean the area after the tick removal, and then sending the tick for potential identification or disposing of the tick. And you can send that tick to Dr. Thangamani's lab, as I'm sure has already been discussed. And I always think it's interesting because how many people are actually carrying tweezers around to be able to pull a tick off. But I think as Dr. Polino had showed yesterday, if you'd seen that video by Dr. Glaucom Flecken, I'm probably butchering his name, he said that of course he's got tweezers as he's walking through and doing a hike. So maybe more people do have tweezers than we think. The other thing that I wanted to talk about is what's known as doxycycline prophylaxis. So prophylaxis is the same thing as prevention, means the same thing. And this is recommended in certain individuals if the following criteria are met. So the attached tick can be identified as the Zoetis scapularis, which is really hard because nobody is really going to be able to tell if the tick is for sure a Zoetis scapularis just by looking at it. But given that we're in a Lyme endemic area, we can generally assume that maybe this is the tick that we're thinking of. This is again the same tick that it's also known as the deer tick or the black-legged tick. The second is that the estimated time of attachment is greater than 36 hours. So this is also another challenge because it's not like somebody is sitting there with a stopwatch and pushes start when the tick attaches and is waiting 36 hours to say, yeah, it was attached for more than 36 hours. Well, it's just not realistic. So generally what we use as a marker is if the tick is engorged. So it looks like it has taken a sufficient blood meal. And then that doxycycline can be started within 72 hours of tick removal. And this sometimes can be a challenge just because we need to take into account recognition. Can these individuals go to a provider and request or actually be evaluated for potential doxycycline prophylaxis? Can they call up their primary care provider to get this prescription? Then the prescription has to be sent to the pharmacy. Pharmacy has to prepare it. And then the individual has to pick it up as well. So there's a lot of logistical challenges or barriers associated with this too. Lyme disease is common in the area. We checked that box off already. And then no contraindications to doxycycline. So these would be if somebody had an allergy specific to doxycycline, or pregnant women should not take doxycycline as well. So what is this strategy? It's 200 milligrams. So you actually take 2 capsules or tablets together at the same time for a single dose. Where did this come from? What was sort of how did this become a recommendation? Well, there was a study in 2001. So this was published over 20 years ago. And this was a randomized, double-blind, placebo-controlled trial. So individuals were randomized to either receive doxycycline or to receive placebo. So they actually got like a capsule or a tablet that may have looked like doxycycline, but there was no actual medication in it. And they randomized to either receive the doxycycline, 200 milligrams for a single dose, or placebo within 72 hours after a tick bite. And what they were looking at, their primary outcome, was to see if erythema migrans developed, so that bullseye rash. And what they found was that it occurred in 0.4% of individuals who received doxycycline, compared to 3.2% in the placebo group. And this was found to be statistically significant, with this p-value being less than 0.05, and it was 0.04. What they've, when we get some of this information, we can do some other calculations to figure out what's known as the number needed to treat. So what this means is, how many individuals do we need to give this doxycycline prevention strategy to prevent one case of Lyme disease? And that number was calculated out to be 50. So we would need to give 50 people doxycycline at this 200 milligram for a single dose to prevent one case of Lyme disease. Now, the number needed to treat was much less. It was down to 11 if it was initiated with a visibly engorged tick. So that's where that attachment for 36 hours or more kind of comes in. So pharmacists are actually involved in doxycycline prophylaxis. And this is primarily being done, all of this is being done in Rhode Island. So in the state of Rhode Island, they had a law change that allowed pharmacists to be able to dispense doxycycline without a prescription from a provider for this 200 milligrams as a single dose. And the reason for this is because there's so many community pharmacies available and in closer proximity and maybe more easily accessible than going to a provider's office. And there was specific criteria to meet to be able to dispense doxycycline. It's all of that criteria that we had went over previously. So they needed to be in a Lyme endemic area, which they already were with being in Rhode Island. Having that tick be attached for 36 hours or more, or an engorged tick, getting the doxycycline within 72 hours of tick removal, and no contraindications to doxycycline, such as an allergy to doxycycline or a pregnant female. And if they didn't meet that criteria, then they would not get the doxycycline prophylaxis, and they would be referred to follow up with their primary care provider or a provider that that they would regularly go to, or maybe an urgent care clinic, for example. And they will also take the opportunity to provide education if they do start to develop some signs and symptoms of Lyme disease, to again be referred and to go to seek a primary care provider or urgent care, for example. So it's really interesting. I think it's a really great approach to expand access and make it a more feasible process for individuals. And this is something that I'm really interested in potentially working on in the state of New York. What about a Lyme vaccine? So you may or may not have heard of Lymerix. This was an outer surface protein A vaccine that was approved in the late 1990s. It was shown to be immunogenic and efficacious, but there was some controversy over Lyme arthritis type symptoms in vaccine recipients, and that there was also insufficient consumer demand. So this was actually discontinued by the manufacturer in 2002. I don't think we'd run into the problem of insufficient consumer demand now. This was 20 years ago, and I think we're in a completely different Lyme disease world than we were at that point in time now. But there is another Lyme disease vaccine candidate, VLA15, that is in phase 3 human trials currently. It is a multivalent protein subunit vaccine that again targets that outer surface protein A of Borrelia burgdorferi. It's a really interesting vaccine on how, or vaccine mechanism on how this works, but it actually uses different outer surface protein A epitopes, trying to kind of get rid of some of the potential issues that were noted in the Lymerix vaccine. And last but not least is education. So I think we're doing a great job with education being here at this summit. providing more education to patients as well as clinicians and the community on how we can recognize the signs and symptoms of Lyme disease, how we can improve accessibility to be able to recognize and be evaluated for Lyme disease, to increase the or to decrease the time to appropriate treatment, and then how can we actually prevent this from occurring in the first place. So I think education is key, and this is something that will need to be ongoing. So I have a second interactive question. We have a 25-year-old female who presents to her primary care provider's office after she frantically noticed that she had a tick attached to her right lower extremity, so her right leg. She presents to her provider on Monday at 9 a.m. with the tick still attached. The provider notices that the tick is engorged and it appears to have black legs, Zoetis scapularis, assuming that. She recalls that she was running at a New York State park on Saturday between noon and 2 p.m. She denies any infectious related symptoms. So she doesn't have any fever, any muscle aches, any pain, headache, fatigue, anything like that. The provider appropriately removes the tick and is considering post-exposure prophylaxis with doxycycline, but is unsure if she meets criteria. Which of the following is the most appropriate recommendation at this time? So recommending doxycycline for a single dose. Do not recommend doxycycline because the patient waited too long to seek medical care. Do not recommend doxycycline because the tick has not been attached for long enough. Or recommend Lyme disease diagnostic testing. So how many people by show of hands say A? Okay. B? Okay. C? And D? Good. Nice job. So doxycycline for a single dose. So this tick was engorged, so we can, assume that this was had been attached for more than 36 hours or more, and also based on the timeline here. And given that the tick is being removed at the provider's office here and their prescription can be sent, it's likely that this individual is going to have doxycycline within 72 hours of tick removal. And there were no contraindications to doxycycline that were noted here. All right, nice job. So in summary, doxycycline remains the mainstay of treatment for early localized Lyme disease. Ceftriaxone and/or doxycycline is the recommended treatment regimen for early disseminated Lyme disease. And tick bite prevention is essential to prevent tick-borne infections, and doxycycline may be appropriate in certain patients for post-exposure prophylaxis when select criteria are met. So with that, I'd be happy to take any questions.
Thank you, Dr. Kufel.
Hi, Wes. It's Brian. Great talk. I have a question regarding treatment of individuals that are pregnant. What do you recommend?
Yeah, that's a great point. So the other two antibiotics that were listed there, so amoxicillin and cefuroxime, can be used in pregnant women. So that's a great question.
Who else up front, Doctor?
I have a couple different questions and just information what I do. The last presentation for a patient who came in like that, I would test them for Lyme's disease, even though I would treat them with doxycycline. First off, that person has had high risk of getting Lyme's disease, may have gotten it 2 weeks ago and you don't even know it yet. So if she's got a positive test, I would extend the treatment. So that's just what I do. If my patients test positive for Lyme disease, I give them a 21-day course of antibiotics and I give them a refill. And I tell them if they tolerate it for 21 days, they should take it for 42. And the reason I do that, my thought process is I give teenage kids minocycline, tetracycline, doxycycline all the time for acne. So if they're tolerating it, I'd rather over-treat Lyme's disease than under-treat it. The question I have more than anything else is, do you do any prophylaxis for the person who's pregnant and has a tick bite, or anaphylaxis to doxycycline, and you can't give doxycycline as a preventative treatment?
Yeah, no, that's a great question. And thanks for bringing up those comments and points. I think that goes to show there is a lot of variability in kind of the management of patients who have a tick bite and may have Lyme disease. And this is, again, just based on your own clinical experience and practice. And I kind of just wanted to reemphasize a lot of that is what was based on the Infectious Disease Society of America guidelines. So that's where the treatment duration was primarily coming from there. And you bring up a really great point about the Lyme disease prophylaxis strategy. If it is a pregnant woman or somebody with anaphylaxis or a severe allergy to doxycycline, that would preclude that. But in that study that I had reviewed by Nadelman and colleagues in 2001, they actually excluded patients that met those criteria. So that had basically an allergy to doxycycline or a pregnant woman from getting doxycycline because of the potential risks. So in that population, it's not exactly clear on what we should be using for prevention if we're using an antibiotic. There is some older data on using antibiotics for prevention, including like amoxicillin and some of the other, and doxycycline as well. But the treatments or the durations are often pretty much similar to what we would use for treatment. So I didn't include those in this talk, but there is some older data on potentially using alternative options for doxycycline. That's a great question.
What would you ask your physician to give her?
I don't know if he can hear you.
Oh, sorry.
Hi, Wes. It's Chris. I can probably answer that because I think
Question.
the question was if your wife was pregnant, 3 months pregnant, what would you give her? I have my answer. I don't know if you want me to take it.
Sure, you can. Yeah, go ahead.
So I think, I'm not a pediatrician at all, but I have had this question come up a lot. And before they kind of made those recommendations about doxycycline in children, I believe, and correct me if I'm wrong, for any family practitioners or pediatricians in the room, I thought it was a 10-day course of amoxicillin for post-exposure prophylaxis for kids. And that's what I've seen given to a bunch of children. I would probably do the same thing with a pregnant individual or somebody who had a really severe allergic reaction to tetracyclines. I'd probably go with 10 days. I've offered that to some pregnant women who have had tick bites, and for whatever reason, they were, I know the reason. They were pregnant. They were very anxious about taking anything in the setting of the pregnancy. And they opted to do more of a watchful waiting approach, and it was fine. They had no problems. They didn't develop Lyme disease, but I think amoxicillin is the drug that I would use.
Yeah, I was just going to agree with Dr. Polino. Amoxicillin is an antibiotic that we have a lot of good data that it can be used in pregnant women. So that would be a great option.
Hi, thanks so much for that talk. I had a question about identifying the ticks, because it seems like in terms of being able to access the post-exposure prophylaxis, there's a couple barriers, and one being able to get in to see a provider. So the example of Rhode Island was really interesting, but the other would be identifying the ticks. And I was just curious, I don't know if Dr. Thangamani or you might know the answer to this. Are there cell phone apps, for example, that can help you identify the ticks and remove some of those barriers of actually needing to have a tick in hand at the provider's office?
Yeah, that's a really great point. I mean, it is, somebody could just Google search a picture of a black-legged, of the deer tick or black-legged tick to kind of get a sense of what it looks like. I'm not sure if there's any apps available. Dr. Thangamani might have some good information on that, but it is a barrier to be able to recognize, what type of tick this is. But generally, if we are in an area where, Lyme disease and the zotoscapularis ticks are present, a lot of times we just end up assuming that is the tick. We'd rather be a little bit more overcautious and conservative than not, but it's a really big challenge. It's a great point.
Katie, for your question. I don't think there is any real-time identification of ticks based on just, like you show your phone camera to it. But however, you can take a picture and send it to a third party, like Tick Encounter or a lot of other places there that they can take maybe a couple of days to get back to you, say, hey, this is the tick. So there are there, but it's not a real time. You can show and it tells automatically. No, it's not, unfortunately.
Other questions for Wes Kufel?
Oh, sure, of course. It may not be perfect, but there's National Geographic Seek app. Have you seen that? And so that did come up as a tick. It didn't tell me what kind of tick, but it says tick. So at least that'll steer you in a direction.
There actually is a tick tracker app. It was created by a 13-year-old girl and her father, who is an app developer. She has Lyme, the Live Lyme Foundation. You can find it in all the app stores, and people can report ticks in real time on a national map. So it just might be something to look up as an option.
Thank you. Other questions? Yeah, up here.
So the question is about if the tick is partially removed and it's like within 24 hours. And now I guess, I would just treat it but it wasn't my, practice in the past. And what is the chance would those patients actually develop Lyme disease if the ticks are just partially removed?
Yeah, that's a great point. And when we look at that, and I think this is when we look at that doxycycline prophylaxis study, it's really only based on one particular study with not huge numbers in that. And that's what we're basing a lot of this doxycycline prophylaxis recommendations on. So I think that we really do need some more information to kind of help support, is this something that we should be really doing? But I think that's, a whole nother separate topic. But for the partially removed ticks in that particular study, I don't recall if that was anything that they specifically looked at, if it was fully removed or partially removed. But from my, I guess just from my perspective, I think that it would be reasonable to do the doxycycline prophylaxis if it was still partially removed, and if the individual did not have any specific signs or symptoms of Lyme disease at that particular time, and to just educate the individual and say, if you do end up developing any signs or symptoms of Lyme disease, to seek medical care so that you can actually get a full treatment course of doxycycline for Lyme disease.
Okay, I don't want to leave any questions on the floor. We do want to move on to our patient panel, Dr. Augustine.
Just again, what I do with those patients, I give them the option of one of two things: not do anything, give the doxycycline, or with a 2 millimeter punch, I'll punch out that head and then it's gone. So I give them the option. If they're really anxious about it still being in, it takes 5 minutes to do a 2 millimeter punch and just remove the head. But I treat them either way.
Dr. Polino?
That's great. Thanks.
Yeah, I think I would just treat with the doxy prophylaxis. I think having the head left inside, it doesn't really matter, to be honest. I mean, I've learned a lot from this guy next to me in terms of the biology of the ticks and how things actually work. And I think a lot of people think that these biting insects, it's a hypodermic needle that injects something into you right away. And that's just not how the biology works. So if you leave the head in, then you're either already infected because it was attached for too long anyway, or it was under the 24 hours and the spirochetes have not made it to the salivary glands yet and have not actually infected you. So the head of the tick doesn't bother me whatsoever.
Other questions before we thank Dr. Kufel for his wonderful presentation? Anybody else with a hand up? All right, doctor, thank you.